Thank you, and thank you for having me here today. My name, as mentioned, is Andrew Katims, and I'm currently in my last year of fellowship at Memorial Sloan Kettering. And as mentioned, I was at Mount Sinai before that. In entering an oncology fellowship and ultimately an academic career, my goal has been to understand the basic science of disease and use that knowledge to directly impact patient care. Today, I'm going to discuss the work that I started in fellowship and plan to continue throughout an academic career. The topic for today's talk will be the past, present, and future of risk stratification for upper tract urothelial carcinoma. So my disclosures. The outline for today's talk, after a brief background and case presentation, will be focused into three categories. We will discuss the importance of risk stratification for UTUC and some of the challenges of the past utilizing only clinical variables. We will then discuss the present state of genomics and the tumor microenvironment. And finally, we will go over some future directions utilizing liquid biopsies and urine-based biomarkers. Upper tract urothelial carcinoma is a rare and highly lethal form of urothelial cancer involving the renal pelvis and ureter, and it's been glaringly understudied, representing a seriously overlooked and unmet need in oncologic care. It accounts for 5 to 10% of all urothelial cancer diagnoses and has similar risk factors and presentations to bladder cancer, with the largest risk factor being exposure to tobacco. Patients will typically be symptomatic, with over 50% having gross hematuria and some presenting with flank pain. Patients with Lynch syndrome are at significantly increased risk of developing upper tract disease compared to the general population. Lynch syndrome is an autosomal dominant familial genetic condition that significantly predisposes individuals to certain cancers. We know that the key genes mutated are MLH1, MSH2, MSH6, and PMS2. Mutations in these genes cause dysfunctional DNA mismatch repair. Tumors typically manifest with microsatellite instability. And because of this, patients with Lynch syndrome typically respond extraordinarily well to immune checkpoint inhibitors such as pembrolizumab, which is approved for tumors with high microsatellite instability. The AUA now recommends Lynch testing for all patients diagnosed with upper tract urothelial carcinoma, which is in line with many other association guidelines for screening patients diagnosed with Lynch-related cancers. Once diagnosed with upper tract disease, patients are risk stratified to determine appropriate treatment. Shown here are the European Association of Urology guidelines, which until recently were the only guidelines available. Ultimately, based off of these guidelines, few patients were eligible to undergo kidney-sparing surgery or endoscopic management, leading to overtreatment. But we know that advanced upper tract disease can lead to cancer-specific mortality, and radical nephroureterectomy can cure a large proportion of both low-grade and high-grade patients. So why don't we just take out everybody's kidney? Cancer control has to be balanced with the risk for chronic kidney disease. At baseline, nearly half of patients with upper tract disease will have some degree of CKD, and after nephroureterectomy, up to 85% of patients will progress to stage 3 CKD or greater, which not only makes them ineligible for platinum-based chemotherapy, but also increases their personal risk of overall mortality. Outside of the personal risk to patient care, there's a massive public health burden of CKD and renal replacement therapy. In 2020, patients with CKD accounted for nearly 1/4 of all Medicare expenditures at $85.4 billion, which is double the cost per person compared to those without CKD. So as such, appropriate risk stratification can not only help patients, but also help the general population. The AUA has taken the need for improved risk stratification into account in their latest guidelines. However, as we will discuss, there remains an unmet need for a more granular definition of risk. Moving on to our case presentation. This was a patient that we saw at MSK. He's a 76-year-old male who came in with gross hematuria after starting Eliquis for newly diagnosed asymptomatic AFib. His past medical history was significant for hypertension, AFib, and a hernia repair. He underwent a gross hematuria workup. His urine culture was negative. His voided cytology was atypical. His creatinine was 1.2 with a GFR of 63. He underwent a CT urogram, which revealed a relatively large filling defect in the right UPJ, as you can see by the red arrows, which caused some upstream hydronephrosis. The patient then underwent a ureteroscopic biopsy, which can be seen here. You can see here a typical biopsy from upper tract patients. There's papillary architecture, as is common in most urothelial cancers, but it's fragments of tissue that are detached with no lamina propria or muscularis seen. So as such, the report read non-invasive low-grade urothelial carcinoma. So with this information, what are the next steps? To summarize, we have a 76-year-old man with stage 2 CKD with a large obstructing but low-grade tumor in his proximal ureter. The European Association of Urologists guidelines classified this patient as high risk and recommend nephroureterectomy. The AUA classifies this patient as unfavorable low risk, which he may be offered ablative therapy. So we have to ask, can the tools of the past help us appropriately make the treatment decision for this patient? Upper tract patients face many challenges with accurate diagnosis and surveillance. Despite now being recommended for most patients, ureteroscopy is invasive, inaccurate at staging, and is a risk factor for intravesical recurrence. Urinary cytology is particularly poor for upper tract disease. While utilizing selective cytology does improve the sensitivity of detecting high-grade disease, a positive urine cytology in an overall cohort has a sensitivity of 56% for high-grade disease and 62% for muscle invasion. One major problem is the inaccuracy of our diagnostic tools. The data shown here are from an MSK cohort in which we looked at patients that underwent ureteroscopic biopsy followed by radical nephroureterectomy, and the results you can see here are generally in line with those available in the literature. We have a non-diagnostic rate of 13%, an overall grade concordance of 80%, and a 32% stage concordance. The grade concordance, however, is driven by high-grade disease. And if we take a closer look at this grading concordance, when we consider tissue alone, we can see that all patients that had a high-grade disease on ureteroscopic biopsy ended up having high-grade disease on nephroureterectomy specimen. However, almost 60% of patients reported to have low-grade disease ended up being upgraded to high-grade disease. And this was a cohort of patients that, for the most part, underwent immediate treatment. A closer look at these 28 patients based off of a pathology report alone revealed that 9 had mixed low and high-grade tumors. 1 did have a slow progression over time from low grade to high grade, and 18 had no low-grade disease reported on final pathology. In consultation with our pathologists and undergoing re-review, these 18 were mostly mixed low and high-grade tumors. But tissue doesn't live alone in a silo. If we add cytology into the picture, we can reduce the number of false low-grade results. However, we still have nearly 50% of patients that have low-grade tissue with a negative or atypical cytology, and then get upgraded to high-grade disease on final pathology. It should also be noted that by adding cytology, there's now a risk of overtreatment in about 30% of patients that were diagnosed with low-grade disease on biopsy and suspicious or positive cytology, and subsequently only had low-grade disease on their final surgical specimen. Tissue is very discordant, and this favors TA disease, which is not a true diagnosis of TA disease, but as we discussed, just a representation and a limitation in our instruments at obtaining deep tissue samples to accurately stage patients. Aside from the inaccuracy, there are risks associated with undergoing ureteroscopic biopsy. This was a study we published 2 years ago. We looked at a multi-center cohort of 485 patients with upper tract disease that underwent either robotic or laparoscopic nephroureterectomy. Our primary endpoint was intravesical recurrence. Overall, 22.7 patients developed intravesical recurrence, and importantly, a risk factor for developing bladder recurrence was ureteroscopic biopsy. However, both the EAU and the AUA recommend risk stratification with a primary split point based off of grade, which makes us ask if stage even matters in determining the treatment. And while clinicians are less likely to be unable to determine candidacy for endoscopic management versus nephroureterectomy, nuances such as the decision to deliver neoadjuvant chemotherapy or perform a lymph node dissection may be impacted by stage. Though there's now level 1 evidence from the POUT trial for adjuvant chemotherapy, as mentioned previously, up to 85% of patients will have stage 3 CKD or worse after nephroureterectomy, which limits the delivery of appropriate therapy to these patients. As such, a phase 2 multi-center study showed efficacy of split-dose gemcitabine and cisplatin for neoadjuvant chemotherapy. The study found a 63% downstaging rate to less than PT1 and a complete response of 19%. But we have to keep in mind 2 factors. As we discussed previously, it's impossible to know the true stage prior to surgery for this, so the downstaging rate may be overestimated. And if we compare these rates to bladder, you can expect to see almost a double a complete response rate in bladder of about 35 to 40%, which really underscores biologic differences and differences in treatment for these 2 patient populations. However, the AUA does recommend consideration of neoadjuvant chemotherapy for high-risk disease. This is based off the association of high-grade tumor being found on ureteroscopic biopsy with high-stage disease on final pathology. There was a meta-analysis performed, which found a positive predictive value of 60% and a negative predictive value of 77% for high-grade disease, correlating with high-stage disease. But when we look at our own cohort, we can see that there's significant risk stratification migration, which indicates there's significant room for refinement. Similarly, the guidelines recommend lymph node dissection based off of low versus high risk. Several retrospective studies have shown survival benefit of a lymph node dissection in higher stage patients, but this is likely just a reflection of a higher probability of finding and removing positive lymph nodes in high stage patients. Like in bladder cancer, the probability of having a positive lymph node with PT1 or lower disease is very low. In this study, it was 5%. As such, appropriate staging may improve patient selection. Many groups have developed models and nomograms to identify patients that harbor high stage disease. The top study by Petros had the highest AUC of 0.82, though in general, most models identify similar predictive variables. These include advanced age, high grade on biopsy, sessile tumor architecture, low hemoglobin, high neutrophil to lymphocyte ratio, and invasion or hydronephrosis on imaging. And in general, the models all have an AUC which hovers around 0.8, which generally outperforms biopsy alone. Moving on to our current knowledge and our progress in understanding genomics and the tumor microenvironment. While UTUC is similar to urothelial cancer of the bladder, arising from the same urothelial layer as bladder cancer and sharing some mutational similarities, they're not equivalent. While there are important clinical differences, there are also distinct genetic differences which may alter management strategies. Distinguishing features of the genomic landscape of primary upper tract urothelial carcinoma was first described by our group in a series of 83 patients with primary upper tract cancers and compared to TCGA bladder cancer data. This comparison revealed that UTUC was a unique genetically diverse disease enriched in key associations such as hypermutation subtypes such as Lynch syndrome, which accounts for 21% of upper tract cases, and a high incidence of potentially actionable genomic alterations, including recurrent activating mutations in receptor tyrosine kinases such as FGFR3, ERBB2, HRAS, PIK3CA, and TSC1. Our group has also analyzed matched tissue concordance between sequencing biopsy specimens and tumors from radical surgery. Though this was a small cohort, we found that limited tissue obtained on ureteroscopic biopsy had significant overlap in mutational profiles to that from radical surgery. Using this information, we then identified a genomic classifier that could predict T3 stage or greater. This ended up consisting of a 2-gene classifier in which FGFR3 was classified as favorable, TP53 was unfavorable, and a combination of both was intermediate. Ideally, this classifier could be applied to sequence biopsy specimens given the concordance presented on the previous slide. However, this was a small size cohort. There was a lack of a validation set, and there are multiple clinical variables that are likely important. So we hypothesized that there's more complexity and sought to improve and expand upon this model. So we evaluated a retrospective cohort of 242 chemotherapy-naive patients that underwent nephroureterectomy and next-generation sequencing with MSK-IMPACT. MSK-IMPACT is our in-house next-generation sequencing platform, which is a targeted sequencing platform panel that covers 505 genes. In our cohort, diagnoses were dichotomized into low stage, which we defined as less than T2, or high stage, which was greater than or equal to T2 stage based off of final pathology. Genes that were mutated with at least 5% prevalence and were oncogenic or likely oncogenic based off of OncoKB annotation were included. And as you can see, we considered several models. We reported the AUC, the sensitivity and specificity of each model. In this case, the sensitivity refers to the proportion of high stage tumors that were predicted to be high stage, and specificity refers to the proportion of low stage tumors that were predicted to be low stage. In general, our models were able to have a high specificity to predict low grade, but a mediocre to truthfully poor sensitivity in predicting high stage. Ultimately, we chose a 3-gene model, which consisted of TP53, FGFR3, and HRAS. HRAS mutations were significantly associated with increased likelihood of low-stage disease after adjustment for TP53 and FGFR3. Our multivariable logistic regression model with TP53, FGFR3, and HRAS was selected as the optimal model with a median AUC of 0.79, a sensitivity of 0.6, and a specificity of 0.78. FGFR3, HRAS, and TP53 have more to their story. These genes have been previously identified as having unique transcriptional expression, and these correlate with distinct molecular clusters. This was a study, a collaboration study between our group and a Japanese cohort with Dr. Fuji, and we performed RNA sequencing on 114 patients, and we were using unsupervised bulk sequencing. We identified 5 distinct molecular clusters, and these molecular clusters corresponded specifically to different mutational patterns. In particular, there is a hypermutated pattern, an FGFR3 mutated, RAS mutated, TP53 mutated, and triple negative. And this underscores some biologic differences between these mutations. We've done further work to show that cluster analysis, in addition to corresponding to different stages, is also associated with survival outcomes. This is a separate cohort in which you can see cluster 5. Cluster 5 here is enriched in FGFR3 and HRAS mutated tumors and has overrepresentation of PTA and PT1 tumors. Cluster 4 is a mixed cohort. Cluster 1 is enriched in FGFR3 and is again overrepresented in low stage disease. And clusters 2 and 3 are enriched in TP53 and triple negative tumors, and as expected, have a higher proportion of T3 and T4 tumors. In line with our model, FGFR3 and HRAS are associated with low stage and have the best survival outcomes, while TP53 and triple negative tumors are associated with high stage and have the worst outcomes. Since FGFR3 is the most common mutation in UTUC and response to immunotherapy is correlated with T cell enrichment and location within the tumor microenvironment, we perform single cell RNA sequencing on treatment naive UTUC tumors to further delineate tumor microenvironment in FGFR3 mutated tumors. 2 studies to date have utilized bulk RNA sequencing to evaluate the tumor microenvironment in FGFR3 mutated upper tract tumors. One suggested a T cell depleted phenotype, and the other suggested a T cell infiltrated phenotype. Further, though mentioned previously, how patients with Lynch syndrome respond well to immune checkpoint blockade, few studies evaluate the efficacy of immune checkpoint inhibitors in UTUC specific population. In our group, we found that FGFR3 mutated tumors were immune infiltrated. However, the immune infiltrate was enriched in naive CD8 cells as well as Th17 like CD4 cells with low cytotoxic activity. So the general picture painted here is that though they're immunologically infiltrated, they're not immunologically active. Though this is only hypothesis generating, you can imagine an approach that instead of recruiting T cells to the microenvironment, instead activates T cells to create a robust response to therapy. One noteworthy finding here is that the FGFR3 mutated tumors have an immune microenvironment, which is suggestive of tertiary lymphoid structures, though this is yet to be proven. So using this information and our current tools, could our model have helped our patient? He underwent sequencing of his biopsy tissue, which revealed FGFR3, KMT2D, and STAT2 mutations. And though it's not perfect, perhaps in the setting of a low-grade biopsy, in addition to an FGFR3 mutation with no TP53 mutation, we, as well as our patient, may have been more confident in our decision to avoid radical surgery. One of my research goals was to not only further inform risk, but also to eliminate potentially unnecessary invasive procedures. My hypothesis was that the genetic material in urine of patients with upper tract disease can be sequenced to identify meaningful alterations. And this brings us to the future, utilizing non-invasive biomarkers to define risk. We've all probably heard the term liquid biopsy, which is now one of the hot topics in most fields of oncology. But I think it's important to understand and define what this actually is, as well as the separate components of it. So a liquid biopsy is a generic term that refers to any non-tissue based biopsy. It can come from multiple different sources depending on the disease that you're interested in studying. As you can see in this picture here, you'd probably not want to study saliva if you're looking for bladder cancer. Within each compartment, there are multiple different components that can be studied. And this includes circulating tumor cells, circulating nucleic acids, tumor-derived fraction of cell-free DNA, as well as cell-free RNA, which consists of mRNA, long non-coding RNA, and microRNAs, extracellular vesicles, tumor-educated platelets, proteins, and metabolites. And although there are several components, these different tumor-related components make up an extremely small fraction of samples obtained. If we take the consideration of a metastatic patient, which you'd expect to have a high fraction of tumor-derived components, intact circulating tumor cells are found at a low frequency of often less than 10 cells per cc of blood. Cell-free DNA, or cfDNA, refers to fragmented DNA that's found in the non-cellular compartment of blood. Cell-free DNA is released into the bloodstream through apoptosis or necrosis. Under normal physiologic conditions, cell-free DNA is found in plasma at low levels, but it can increase under conditions of tissue stress, such as exercise, inflammation, surgery, tissue injury, or cancer. Typically, cell-free DNA is cleared from circulation with a half-life of an hour or less. the fraction of cell-free DNA that's derived from tumor is circulating tumor DNA, and this can range from 0.1% to 93% of the cell-free DNA that's found in serum. This wide range reflects a variety of factors, though in general, the fraction of circulating tumor DNA tends to parallel tumor burden within an individual patient. And I think an easy way to understand this is by considering a bladder. If we consider CIS, superficial lesions, they don't have access to larger blood vessels, but as the tumor invades through the lamina propria and muscularis and has access to the deeper blood vessels, it can the cells can necrose and apoptose and release their contents into the bloodstream, which can then be studied. Advances in specialized cell-free DNA collection tubes contain fixatives which can stabilize both cell-free DNA and intact cells for 7 to 14 days at room temperature. However, the lack of standardized pre-analytical conditions or methods for isolating cell-free DNA limit the clinical utility and interpretation. If we consider just the collection tubes alone, there's currently 9 commercially available tubes for the preservation of cell-free nucleic acids. After that, we must decide which assay to use, which can be determined based off of the question that you're going to ask. If you're just looking to find the presence or absence of DNA, utilizing something at the bottom of this figure here, such as droplet digital PCR, which has a very good sensitivity for detection, but cannot detect many mutations, might be your assay of choice. But if your goal is to characterize the tumor genome to identify druggable targets, resistance markers, or follow evolution of tumor genome over time, you may want to consider whole exome or targeted exome sequencing, which has less sensitivity, but a broader coverage of genes. One important technical factor is that these samples generally undergo centrifugation with the cell-free DNA located in the plasma, but there is an important layer here called the buffy coat, which is basically white blood cells. And it's important to utilize these as well to look for germline variants and to rule out clonal hematopoiesis. The current landscape of blood-based assays for urothelial cancer is dominated by a company, Signatera, which is a branch of the Natera group. Signatera is CMS reimbursable for the detection of minimal residual disease after radical cystectomy. And it's been shown to be highly predictive in several trials of disease recurrence. Signatera positivity generally precedes clinical evidence of recurrence by as much as 200 days with a 100% sensitivity and a 98% specificity. The way this test works is you send a tissue sample to the company, they perform whole exome sequencing and create a customized tumor panel, which can then be applied to blood samples and they utilize ultra deep sequencing PCR methods to report a positive or a negative result. On the other hand, MSK Access, which is again an MSK assay. It's in-house, it's fully clinically integrated platform, and it does have New York State Department of Health approval for sequencing all tumor types. The platform is similar to MSK Impact, but one benefit of this is that it uses a tumor-naive approach. So you just submit blood, you do not have to submit any tissue. It currently covers 129 genes. We're coming out with a new version, which should be expanded. It's important to note that this is much less sensitive compared to Signatera, but I believe that utilizing targeted exome sequencing platforms for this purpose has more clinical and research applications because you can not only follow tumor evolution, but you can apply them to give targeted therapies. So urine, like blood, has several different compartments and components that can be studied. It has the added benefit of being completely non-invasive with an opportunity to collect samples at home. And additionally, it seems to be an obvious choice for urothelial cancers. However, it's an extraordinarily challenging fluid to work with. And this is due to high levels of DNase activity and leukocyte apoptosis, which causes significant background contamination. So because of this, urine has to be processed immediately or collected in a cell-free DNA collection container, and if not, then urinary tumor DNA typically becomes unmeasurable. And this limitation has led to essentially the inability to utilize this practically in a clinical setting. Thinking about only the cell-free compartment of urine, there are two main sources. There's cell-free DNA, which is directly from urinary tumor cellular apoptosis and necrosis. And then there's transrenal cell-free DNA, which is circulating tumor DNA that has undergone glomerular filtration. These can be separated based off of molecular weight. High molecular weight cell-free DNA typically comes directly from the urothelial cells compared to low molecular weight, which has been filtered from circulation. Utilizing differential centrifugation allows for separation of some of the components. The heaviest components are the intact cells, which can then be evaluated both cytologically and genetically. The supernatant contains cell-free DNA, which can be precipitated and extracted using a variety of methods. And then there's a layer in between the cellular and supernatant layer, which contains extracellular vesicles or exosomes. There have been several commercial-based urine assays that are available, but essentially none of these have made it into routine clinical practice. And there's several reasons for this. First, many lack the sensitivity and specificity to outperform cytology with or without cystoscopy. Some are limited by high costs. And most importantly, they fail to answer a clinical need. There are two tests that have had greater success, the CX bladder monitor test, which can be done in a patient's home, and Uromark. However, we have to be cognizant that a diagnostic assay, unless it's providing genetic information or can guide therapy, is of limited clinical value. The goals of liquid biopsy in urothelial cancer are to reduce the need for frequent invasive procedures, to exclude recurrence, to detect progression towards invasive disease, and to predict effective treatment response. As we just discussed, many of the urinary tests have been developed for bladder cancer, and they've been tested in very small UTUC populations. Here we can see a few of the studies that assess urinary biomarkers in UTUC specific populations, and some even achieved an excellent sensitivity and specificity. However, these tests were developed as a diagnostic test to answer, is disease present, yes or no? And while there's some clinical utility in this, they really miss the mark on more pressing clinical issues that upper tract patients face. So we wanted to ask the question, and the true purpose of the development of our genomic model is, can this model be applied to urine? Ultimately, the endpoint is to utilize a non-invasive test in addition to the normal workup and genomic urinary markers to precisely characterize the patient's disease and enroll them in the proper treatment. However, as we discussed earlier, urine is a difficult material to work with. So the first question we sought to answer is the feasibility of sequencing urine cytology. The process shown here was developed by our cytopathologists at MSK, and it utilizes both urinary cellular material in addition to precipitated urinary tumor cell-free DNA, which can then undergo extraction and next-generation sequencing. What's important about this method is that it doesn't necessarily require any specialized tubes or immediate freezing. We utilize the normal fluids used to create a urine cytology and then essentially add alcohol, so all commonly available in any lab. We applied this method of urinary DNA preparation to selective cytology samples that were collected from patients with upper tract disease. We sent 48 samples for sequencing and were successful in 45 samples, which yielded a 94% success rate. What's important about this is seen here, is that 100% of patients with low-grade disease and negative cytology were successfully sequenced, and our failures were only were due to a processing failure in positive cytology patients. The most common mutations identified were TERT, KMT2D, and FGFR3. And we also compared the mean variant allele frequency among the different cytology results and found generally increasing mean variant alleles from negative to positive cytology. We then assessed concordance of sequencing results to match tissue. Overall, we identified 238 mutations. Of these, 53 were in cytology, only 54 were in tissue only, and 131 were shared, which yields an overall concordance of 55%. But we hypothesized that urinary cytology would have a more representative coverage of the tumor mutational pattern compared to biopsy alone. Therefore, we compared concordance between urinary cytology samples matched with ureteroscopic biopsy tissues and urinary cytology samples matched with nephroureterectomy tissue samples. And we did indeed find greater concordance between cytology and nephroureterectomy compared to cytology and biopsy alone. Of note, we had 11 patients out of 36, so 31% had a 100% concordance. And if we consider at least one mutation shared, 95% of patients had at least one mutation shared between cytology and tissue. Finally, we looked at a pairwise concordance on select common genes. This analysis was in our 36 patients. Overall, we did find a high degree of concordance in key genes such as FGFR3 and other targetable mutations such as ERBB2, PIK3CA, TSC1, ARID1A, TP53, CDKN1A. They were actually identified more frequently in urine cytology compared to tissue. We do have some next steps in this project. We're collecting samples now to have a prospective validation of our model, our genomic model, to be applied to urinary cytology specimens. Ultimately, we'd like to apply this to voided urine. So we are running voided urine samples as well. Another project we're working on is utilizing urinary cytology sequencing for disease recurrence after endoscopic management. And a project that is just getting started is evaluating extracellular vesicles and the urinary RNA and single cell RNA data to non-invasively characterize the tumor microenvironment. We do have several other projects working on cell-free DNA. These are two that I'm leading in muscle-invasive space, utilizing serum circulating tumor DNA to inform preoperative chemotherapy in response to clinically localized and node-positive patients, and in non-muscle invasive bladder cancer, we're attempting to objectively define minimal residual disease by comparing the presence of CIS, urine cytology, and urinary tumor DNA. So to conclude, in the past risk stratification based off of clinical pathologic variables alone does not provide adequate risk stratification. While we can produce models that can improve risk stratification, they still require invasive procedures. We know now that upper tract disease is distinct from bladder cancer, and FGFR3, HRAS, and TP53 mutations can define risk of stage, progression, and disease-specific survival. In the future, urine is an obvious choice for a non-invasive biomarker for studying urothelial cancer, but it has significant practical challenges. We do know that genetic alterations can be reliably sequenced from urinary cytology, and non-invasive evaluation of the tumor microenvironment can guide therapy for decisions for therapy. I'd like to thank everybody involved. This was a big undertaking by our lab and required many more people than can be listed here, especially my primary mentor, Jonathan Coleman, and David Solid, who have provided excellent guidance for me throughout this process. With that, I'll take any questions. Thank you. Yes.
Andrew, a really great talk, awesome body of work. So thanks for sharing that. Can you just comment on the clusters that you all defined for upper tract disease, the C1 to 5? Were any one of those specifically related to like the MSH Lynch syndrome folks?
Yes, there was a cluster 3, that was enriched in Lynch syndrome patients. recurrent, actually, we're trying to kind of expand this more to Lynch-focused patients, but cluster 3 was enriched in Lynch patients. And that is also an important point, is that that I forgot to mention, based off of our urine cytology sequencing too, we can identify Lynch-related mutations. So you can still do the testing for Lynch based off of the urine alone.
Hey, great talk. This is kind of more on the practical implementation of these kind of technologies. I mean, what is your sense that you need for a sensitivity, specificity, or negative predictive value? Like, what levels do you need for us to be able to change our clinical practice? As you mentioned, what's actionable? Kind of I know you don't have the answer necessarily, but what are your thoughts? I mean, what threshold do we need to reach with some of these tests to be able to replace our current practice?
Yeah, I mean, I think that's the big question, right? Because I think the problem with what's been developed is, as I mentioned, is that they're diagnostic tests. So you're doing some tests to say, is disease there, yes or no, but you have a camera that you can look and see if disease is there or not. So, I mean, cytology is easy to outperform. I think making them actionable is really dependent on the question you're asking. So I think it's great for utilizing targeted therapies. You know, FGFR3 I mentioned a lot because it has targeted therapy with erdafitinib. So I think the utility that I see right now is kind of defining them into different treatment, like defining the treatment you're going to choose for these patients. Ultimately, I would love to do a screening test for it, but the truth of it is we're not there for screening tests. Voided urine for upper tract disease it's challenging, especially because many of them are obstructed in the kidney, so you don't get as robust of a response and if you're just taking voided urine. So that's actually why we thought that monitoring voided urine would be better, because they've theoretically already had a laser ablation which cleared the obstruction, and it should, you know, then pass into the bladder if they're having a recurrence after that.
Great talk, Andrew. You know, one of the challenges is this risk of progression from low grade to high grade. Because if you're thinking like, what's the clinical problem you're trying to solve, right? So theoretically, if you're 100% confident something is low grade, presumably you don't do a nephroureterectomy, like you observe them, you ablate them. But I think where you get in trouble is those progression events, right? Like either it comes back. Do you have any data on outcome, right? Like the cancers that were presumably or histologically low grade that progressed, and if there are predictors of progression?
Not yet, but yeah. Great question. That was actually when I was doing this work. That was the same question that I asked. We haven't looked at that yet, but I think it's important to know, because there are patients that progress, and you need to know who those are.
Is it parallel to like active surveillance? I mean, you're essentially doing, you know, endoscopic management is a form of active surveillance, right? You're not doing radical therapy. So there has been a successful application to say, can we predict who may have more aggressive disease or their trajectory is more aggressive?
Right. I mean, the obvious choice that we see is a TP53 mutation, but I don't think that's sufficient in itself. But it might be. We haven't looked yet.
I think one of the challenges is the anatomic one when it comes to low-grade tumors. When someone has a low-grade, or what we suspect to be a low-grade distal tumor, distal ureterectomy and reimplant can be a great operation for them. In the case you showed, there was a pretty bulky, but hopefully probably non-invasive tumor up near the UPJ. There's not a super straightforward nephron-sparing treatment for them.
Right.
When they're big and bulky, laser ablation may be difficult to complete, or may leave them with a stricture. What do you think about other, let's say you could know for certain that was a low-grade tumor, or with greater confidence. What else would you offer them other than a nephro-U?
Yeah, I mean, in the patient that I showed, actually, his case was it started a few years ago, and he was successfully managed with laser ablation only. I mean, there's topical therapies, but there's issues with them, as I'm sure you know, and we need better therapy. I mean, we're doing a trial now using VTP therapy to tries to cover more of the urothelium. But even, I mean, they have the gel-mito, but I think the results of that really, they cause strictures and probably it doesn't work as well. So I think an aggressive laser, even if it's more than one stage, is probably worth a shot, but there are risks associated with it, and I think we need some better therapies there as well.
Great talk. So in addition to this test that genetic analysis that's going on, has there been any advances in real-time imaging? Because there has been some advances with the camera being right up there that you can potentially do a pathologic analysis right off the images.
Not to my knowledge, it's not something we're working on either. So I'm not aware of